Hi, this is John Carney. I'm chair of the Porter Wright Healthcare Practice Group, and I'm here today with my colleague, Kristen Lawrence. We're here today to talk to you about the many changes in telehealth as a result of the COVID-19 pandemic. As a result of the fact that in order to mitigate exposure of patients who are sick or at risk due to other conditions, as well as protect healthcare workers like yourself, it's being encouraged that telehealth be used whenever possible, and it's especially helpful if you establish protocols and procedures for your practice and your clinicians in order to follow these rules. Now, please keep in mind that the healthcare regulatory framework around telehealth is changing on a day-to-day basis because of COVID-19 pandemic changes. So what we're going to present today is current as of March 31st, 2020, but we would strongly recommend that you be in touch with your healthcare attorney to talk about the changes that are happening, given the fact that we are watching changes from CMS, the Department of Medicaid, and others on a day-to-day basis that could directly impact the billing and coding that you're doing for telehealth. A critical takeaway, though, is that increased flexibility and eligibility is being allowed to encourage social distancing while enabling continuing access to care for patients. Our goal in this webinar is to, as expeditiously as possible, walk you through the changes so you can put them into practice at your healthcare practice. Kristen Lawrence is going to get us started by giving you an overview of the changed definition of telehealth during the pandemic and the communication methods that you're lawfully allowed to use for eligible patients. Kristen?
All right, so as John mentioned, I just want to give you all a definition of telehealth as defined by the emergency rules that the Ohio Department of Medicaid issued on March 20th. So as you can see, telehealth is defined as activities that are synchronous, involving real-time, interactive audio and visual communications, as well as activities that are asynchronous and do not have both audio and video elements. So in order to deliver the telehealth services, providers now have a range of communication methods that they can utilize. However, the Department of Medicaid provides that the providers and patients may use only non-public facing methods of communications. So on the panel on your left, you'll see I've listed some examples of non-public facing communication methods, such as video conferencing, Zoom or Skype, fax transmission, phone calls, or emails. On the left, you'll see some public facing methods that you cannot use, such as Facebook Live, Instagram, or TikTok. An easy way to remember which methods are permissible is to essentially ask yourself if the communication method is primarily a social media platform. You'll definitely want to stay away from any of those platforms. It's important to note, however, that the Department of Medicaid is expecting providers to use their professional judgment as to which communication methods are permissible under the emergency rules. So again, on your left, the non-public facing methods are permissible, but use your judgment as to which methods may not be listed here. So we'll be diving deeper into the Medicare and Medicaid specific rules later in the presentation, but I wanted to quickly set out which patients are eligible under the emergency Medicaid and Medicare rules. Providers can now provide telehealth services to existing and new patients, with an exception for patients who are residing in public or penal institutions. They may also provide these services without having first seen the patient face-to-face, which is a major change. This is arguably one of the largest deviations from what you all are used to. There are a few more restrictions for Medicare patients, which are that the providers can do telehealth visits with new and existing patients, but virtual check-ins and e-visits can only be provided to existing patients. So the Ohio Department of Medicaid has also significantly expanded the definition of provider under the emergency rules. Previously, only physicians, psychologists, physician assistants, clinical nurse specialists, certified nurse midwives, or certified nurse practitioners could practice telemedicine. However, as you can see, dietitians, audiologists, physical therapists, and other providers can now provide telehealth services. So there's been a real effort to expand the type of providers who can provide these services so as to keep healthcare systems from being overwhelmed to the extent possible during this time. I'm going to focus a little bit more on the Medicaid-specific rules, getting into the weeds on eligible provider sites and eligible billable services. The next few slides outline the eligible provider sites where providers can practice telemedicine. This first slide shows that independent practitioners, professional medical groups, Federally qualified health centers and rural health clinics continue to be eligible provider sites. The next couple of slides, however, are recently eligible provider sites, specifically what the emergency rule now includes. So again, the department is making an effort to allow more may not be independent practitioners or members of a professional medical group necessarily to practice telehealth so that the state can increase access to care, reduce the number of patients that would otherwise need to travel for services, and just generally reduce pressure on the hospital system. So again, this is just listing out some additionally eligible provider sites: outpatient hospitals, hospitals delivering outpatient hospital behavioral health services, Medicaid school provider programs, community behavioral health centers, and providers of applied behavioral analysis. So the next couple slides are the eligible billable services under the emergency rule. These services apply to Medicaid fee-for-service, managed care plans, and MyCare Ohio plans. This list is decently exhaustive, but it's really only a snippet of the services that are now reimbursable. Previously, there were only about 25 billable services. Now there are closer to 50 or 60. So as you can see, several of the services are now listed here. And this second slide continues to list some of the services, but these are not all of the billable services. The ODM issued an appendix that includes all of the reimbursable services as well as their billing codes. So we will be discussing some of the billing logistics in more detail soon, but please take some time to review the appendix, which is on the Ohio Department of Medicaid's website, and make sure that you are aware of the ways in which you may be able to take advantage of telehealth during this crisis. And now my colleague John will talk a little bit more about billing logistics.
Thanks, Kristen, for walking us through the revised methodologies and eligibility for telehealth during the COVID crisis. The next few slides are going to walk through some of the guidelines with respect to billing. And just to reemphasize, with respect to online digital evaluation and management, any real-time audio, including telephone or two-way audio interactions, are going to work here. Chronic patients who need to be assessed as whether it's an office visit is needed, again, you can use E&M codes with respect to these individuals. Online assessment for patients being treated for opioid and other substance use disorders. Nurse or other staff member cannot provide this service. It's got to be provided by a clinician, but again, you can bill E&M services here. And so again, as we're walking through the billing logistics, it's important to understand that inpatient and outpatient hospital services are eligible here, and appropriate E&M coding is going to allow you to bill for these services. To include remote monitoring. So if an E&M service is provided within the defined timeframes, then the telehealth visit can be bundled in that E&M service. It would be considered in that instance pre or post visit time for the associated E&M service, and thus not separately billable though. Again, no geographic restrictions for these patient locations. It should be initiated by the patient since a copay is required, and verbal consent to bill and documentation is required during the telephone call. Communication can use non-HIPAA compliant technology, which we'll talk a little bit more about, but given the crisis, there's a lot of flexibility that's being given by the federal government, CMS, in particular with respect to HIPAA and anti-kickback. And so again, you want to be consulting with your legal counsel with respect to the E&M codes that you're using, but there's a lot of additional flexibility around these billing logistics. Flipping over here to the next screen. Medicaid-covered services may be provided through telehealth. Medicare services are going to be able to be provided through telehealth. And as we indicated, certainly the locations of services, whether it be inpatient or outpatient or through a federally qualified health center or a rural health clinic, a lot of flexibility here with respect to billing these services. Again, we've got clients who are providing mental health, behavioral health services, who are evaluating patients on an ongoing basis. This crisis should not keep you from being able to see your patients. That's what, in fact, both the federal and state government wants to have happen. That's what private payers want to have happen. And so you should be thinking about putting these policies in place at your practice, especially if you're in a situation where you're not able to do non-essential cases right now. This is a great way to stay in touch with your patients. So now we're going to talk a little bit more specifically about Medicare. Again, there's the list of covered services has not changed, but services may be provided regardless of location. The waivers not changed the type of providers who can provide and bill for telehealth services under Medicare, but services generally billed as if it's provided in person. So again, you are going to be able to bill services that generally were provided in person as a telehealth service under Medicare as well. And again, we would just encourage you to be working on those specific E&M codes with your counsel. Private payers. I know this is something that obviously we're all interested in given the reimbursement levels of public versus private pay. Let's just walk through a little bit of what the private insurance companies have put in place already. Video and audio will work. Telephone only is acceptable. As you all know, that was not the case before this pandemic. But now literally you can have encounters with patients where you're only on the telephone. This will be a billable service. You're going to be able to be reimbursed by the private plan. The telephone visit itself is going to be considered in-network, and the private payer is going to cover. Cost sharings waived for services delivered by participating in-network providers. Again, we're seeing under all these plans that with respect to specific COVID encounters, whether it's testing, et cetera, they're waiving co-pays. And again, so to the extent that you have patients who are calling you and are telling you that they're showing symptoms and you need to send them to a remote place to be tested, all of those co-pays should be waived, and that's something else that you can communicate to your patients. Similarly, under Aetna and United Healthcare, there's no telehealth co-pays under Aetna. Cost waived for network providers delivering virtual care. Again, telephone and live conferencing. It doesn't need to have a video component, which it typically would. Other virtual care apps or services provided as part of the patient's plan is acceptable. Again, similarly, under United Healthcare, as I mentioned, COVID-19 related cost sharings waived. We're seeing that under almost all these private payers. So to the extent that you have patients who are calling you indicating that they have symptoms of the coronavirus, they should be able to have all those costs waived. Again, under United Healthcare, Medicaid Advantage beneficiaries are eligible and commercial members are eligible. All of this you can see right now is being waived out until June. There's an expectation that this likely could extend longer. So again, as we mentioned at the outset, these rules are changing on a day-to-day basis, and it's important that as you put in place policies and procedures for your practice, that you're updating those policies and procedures with respect to telehealth, knowing that there's an ever-changing geography with respect to what is allowed under these policies. And generally, your attitude should be that it's likely that more things are going to be allowed to be coded as telehealth, but again, it's important to consult with counsel and just make sure that you're taking appropriate steps. Just moving forward here a little bit, there's also been changes with respect to prescriptive authority. Obviously, you're seeing patients, but not physically seeing them, so you can't lay your hands on the patient to do a physical examination. Generally, that would mean that controlled substances couldn't be renewed. However, the DEA has gone ahead and waived that in-person requirement for the time being. The provider must meet the following conditions. The prescriptions issued for a legitimate medical purpose, obviously by a provider acting in the usual course of their practice. Communication is conducted using audio-visual, real-time, two-way interactive communication system. Again, there's discussion about whether or not telephonic communication alone would be acceptable. We would encourage you to be working with your counsel on that. But as long as the provider is acting in accordance with applicable federal and state law, they are allowing refills of controlled substance prescriptions. So again, if this is something that impacts your practice, you have patients who have a controlled substance refill that they need, but we don't want them to come into the office, you should be in a position to be able to go ahead and refill that prescription for your patient remotely. Most importantly, as we're talking about, a lot of these rules changing, the Department of Health and Human Services has come out and will not audit provider-patient relationships to determine whether a prior relationship exists. The Office of Civil Rights will exercise enforcement discretion in enforcing HIPAA breach and security information. As we mentioned earlier, obviously, you are likely to have communication on the telephone that generally would not be HIPAA-compliant communication, but given the pandemic, there's a lot greater flexibility being provided. We've been having conversations with CMS who are indicating that they are not going to be taking enforcement actions based upon things that happened during the pandemic. Again, this is verbally being communicated to us. We don't have anything in writing that says specifically we are not going to take action against your provider. But again, the expectation at this point is patients need to be seen. We don't want them to be physically seen unless absolutely necessary, and therefore we want to give the discretion to physicians to be making these choices, to stay in touch with their patients and be providing them with essential healthcare services. So again, as I said at the outset, our goal is really to run through this as expeditiously as possible, give you an overview with respect to really what is the changing dynamics with respect to the delivery of healthcare telephonically or vis-a-vis audio and video technology these days, and that's now reimbursable vis-a-vis telehealth reimbursement. Medicaid, Medicare, private payers have all made substantial changes to make this a much more viable way to keep your practice going at a time when non-essential healthcare services are not being allowed, certainly surgical cases that are non-essential, but patient encounters just generally that are non-essential are not being allowed. That doesn't mean that your practice needs to come to a halt. You should really be working with your patient population to stay in touch. Certainly we're seeing a significant uptick with respect to mental health issues and substance abuse issues, and to the extent that you can be providing counseling services to your patients, we think there's a real opportunity here for you to be engaged with your patient population. For myself and Kristen Lawrence, we really appreciate the opportunity. We certainly are available to you and your practice. My direct number here at Porter Wright is 614-227-2179. Kristen, what's your direct number here at Porter Wright?
Sure, it's 614-227-2059.
If we can do anything to be helpful in walking through these changes to telehealth or any of the other regulatory and legal changes that are happening during the pandemic or after, we're happy to make ourselves available. Again, thank you for this opportunity, and we look forward to working with you all in the future.